And welcome to the Trauma Recovery Coaching Summit, which is sponsored by the International Association of Trauma Recovery Coaching. I'm Bobby Parrish, the Executive Director.
And hi, I'm Sarah Parrish, the Deputy Director.
I'm so glad you're here. We have 5 days of amazing interviews with our coaches. We're going to be sharing all sorts of information about trauma, recovery from trauma, and trauma recovery coaching. We do want to issue a trigger warning. Some of these interviews can be triggering, so please use your best self-care while you're watching. We also want to give a little bit of information to you for some of our coaches. They still have safety issues in their everyday life in terms of abusers wanting to find them where they are and cause them harm. So today we're interviewing with Destiny Mowadeng, and she is one that has that issue. So you are seeing her avatar picture today rather than seeing her live.
Thank you, Bobby. So thank you, Bobby, for introducing Desi. So today we have the absolute honour of interviewing Destiny Mowadeng, and today Desi is here to talk to us about suicide. We've missed and dismissed, we've presented with a disability. Hi Desi, how are you doing today?
I'm a little nervous, but I'm doing okay and I'm excited to talk about this.
Fantastic, we're so excited for you to be here as well. So Desi, why is this topic so important? You know, why is it so important to bring awareness to this topic?
It's important for a lot of reasons that I'm not going to specifically cover all of them because we don't have time, but for me it's something personal to myself that I've struggled with, and I made a switch between traditional therapy and coaching, and it actually significantly helped me in that way doing so. There was a lot of things that happened to be missed in a regular therapeutic setting versus a coaching setting that picked up on some of those things is important. And I can understand from both perspectives, because we follow different methods, that they would be missed in one setting and not in the other, but still the person is still a person regardless of mental health and disability or what that looks like or shows up like.
Yes, absolutely. So tell me, what does it show up like? What are if I'm working with a client who's disabled, what should I be looking for that might indicate for me that my client is suicidal that I would not see in perhaps an able-bodied person?
You would kind of probably see this universally between either client, but the example I'm going to use is me saying I feel like I want to jump from a roof. Yeah. Of course, I'm in a wheelchair. That's not physically possible. If I actually kind of get to a point where I figured out a way to kind of navigate that in myself, you're probably too late to jump in at that point to kind of fix it and make it so it's not going to happen.
Yeah.
So you would look for things like that, but then of course you're associating that with, okay, she can't, she's in a chair. So then how much do I worry about it? And the emphasis in therapy tends to be, it can't be completed, so it's no big deal.
Yeah. Yeah. So versus even though it might
us be as coaches would kind of view that really differently. Like, it does matter regardless if you can or can't.
You know, I'm sitting here, I'm so sorry that you were treated that way within a therapeutic setting. And what I'm hearing from you loud and clear today, Desi, is that even if I expressed something that I couldn't actually do, still hear me and recognize that I am feeling suicidal and help me cope.
Yeah.
So what kind of good questions would be helpful then, Desi? You know, if a disabled client came to you, you know, what kind of questions would you ask would be helpful?
Again, some things you would kind of look for that may be going on in the background that might not be obvious in an office would be, okay, first, obviously this person is suicidal, and then investigate how they would kind of go about it. Do they have access to medications? Are they able to administer their own medications? Do they have somebody that's, you know, in their home that does that for them? So you would kind of explore, okay, what different ways could a person complete something like that? Because you know, there's 10 million ways to die, regardless if it's purposeful or not, or with the intent to, which suicide never is anyway. It's about ending the pain. It's not, not death.
Yes. Yes. Absolutely. But I can see, you know, what you're talking about. I think of, you know, a client who is perhaps, you know, pretty significantly disabled so that they are bedridden and they can't get up and get out of bed. You know, there's no wheelchair next to their bed. There isn't any way they can ambulate on their own, but they're telling you that they're in so much emotional pain that they wish that they could die. That's still just as valid a statement about suicide as someone who is able to get up and complete suicide on their own.
Yeah, and another thing that you actually picked up on that was really great is somebody who can be bedridden may still have the use of their hands, may still have their cognitive ability to be able to know when they're supposed to take medications and not supposed to take medications. So a caregiver could leave an entire bottle and water and everything to take medications within reach of the person.
Right.
Which is a bad thing to do if the person is kind of going to use that as their only available option.
It's true. It's true. There needs to be some good safeguarding.
Yeah, definitely.
Yeah.
But first it has to be seen as something that is valid, that needs to be safeguarded.
Yeah. You know, in the title of your topic, you said missed and dismissed. Do you think that's pretty prevalent within the disabled community, that when they express suicidal thoughts or actions, they're just like, it's okay. You know, you can't do much anyway. We'll just ignore you. Does it feel like that's been your experience?
It definitely has been mine. It would definitely depend on a lot of different things. Like I said, you know, preface this to anybody who may be listening that has a disability. I'm very nice, depending on how they're affected and what way they would kind of, you know, complete in some way. But still just as valid as me in that they're still feeling the same way.
Yes. The feelings are the same.
But it's more in kind of a look or a facial expression that you can get from a professional that you kind of know they're going, okay, you're in a chair, you're obviously not going to do X, Y, Z.
Yeah. Yeah.
Which presents a different problem than we have online, even because they see us in an office for, you know, 50 minutes. Right. And that's all they can compare it to unless they question it. And the 50-minute glimpse that someone gets of me in a therapeutic setting is not at all what my day-to-day life is like living in a chair.
Yeah. Yeah. I see that like your day-to-day life is living in a chair. So they see you for 50 minutes and it's so out of context is what I hear you saying.
Yeah, it's like so out of context to assume that somebody who's in a wheelchair can't do XYZ or can do XYZ. That
Yeah.
it's not justifiable to kind of jump to that conclusion without asking a bunch of other questions to see what the case actually is.
Yeah. Yeah. I don't think it's ever justifiable to jump to a conclusion.
True, but people do it and people are human.
Yes. Yes, exactly. So what are some good questions to ask a disabled client to assess them for suicidality?
We've already touched on some of these. We mentioned like their access to medication in regards to them being confined to a bed, or, you know, how they maneuver around the world or their own world.
Right.
Because you may actually meet somebody that actually, in the therapeutic setting, you know, walked into your office in a walker, but at home, because it's in their own safe space, they may never use that walker. So even if something's put out of their reach so they're not able to access it, to use it to harm themselves, it's not fair to kind of jump to that conclusion that they walked into your office in a walker, so obviously they're 100% of the time in a walker.
Didn't cross my mind.
Also, something that popped up that kind of piggybacked from depression to suicide was how I presented or came across and looked. Like, I looked clean. I didn't look like I hadn't taken care of myself, but I have a caregiver who's paid to actually function in that position. So she comes to do her job. Obviously, I'm going to take a bath regardless of how I'm feeling emotionally.
Yeah.
So then you're kind of going off what you know as a therapist, and it's not equaling the same thing.
Yes. Yes. So for someone who might be depressed and able-bodied, it might be easy to identify a deterioration in their capability to shower, their motivation to shower and keep their clothes clean. But for you, because you have that caregiver, it's a whole different ball of wax.
Yeah, it is, because that's what her job is, essentially, because I physically can't do aspects of that.
Yeah.
So she does it, and they don't end up equaling the same thing. You know, I never did any of those things, so, you know, my desire to do them or not to do them,
Yeah.
I just wasn't capable of doing it because I'm physically not capable of doing it.
Yeah. 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 So what are some factors to consider when working with a client with a disability that may not be obvious?
If I were to, okay, I have really poor mobility in my hands. You guys can probably notice it if you've ever seen me type something and then I'll go back 3 hours later and go, all right, that makes no sense because all the letters are backwards, or I typed this letter when I meant that one, and it changes the entire context. So if I can't use my hands very well, I can't very easily manipulate a knife. I can't very easily manipulate a pill bottle to open it. So again, I can't use any of those things to, you know, end my pain.
Yes.
And on the other end of that, if I am somebody who can manage to open a pill bottle, and I'm, you know, deemed responsible and able to cognitively take my medications on my own, so somebody is not watching me, there's nothing stopping me from saying I'm done.
Yeah.
And just taking more than I should.
Yes. Yes. Okay. Would a client with a disability present differently from a typical client? And if so, how would that be?
Again, I think we've kind of, the in-between questions, we've covered a lot of this. But just to realize that, you know, their physical body and their mind kind of, one doesn't, lack of ability in one doesn't mean lack of ability in the other.
Yes. Yes.
So you really do have to kind of know what they're capable of doing, not judging them off that 15-minute that you get to see them in a week.
Yeah.
If you're dealing with somebody that's coming to your house, how did they get there? Did they use a caregiver? That could be an indication that if they're starting to be someone that misses appointments, is it them that doesn't want to go, or is it the caregiver's unavailable?
Yes. Yes. So to have a good understanding of their caregiver's role in their life.
Or anybody that's helping them function, because unfortunately that, you know, it doesn't always, but for the most majority of the time, it depends on somebody else.
Yes. Yes. In your experience, Desi, in interacting with other disabled individuals, do you find an uptick of suicidal ideation amongst those with disabilities as opposed to the able-bodied individuals that you would work with?
That's actually really a sad question.
Ah,
And it's not that it's sad, it's just that, again, that piggybacks off the fact that suicide is largely viewed as, okay, it's not safe. It's somebody, you know, not in a safe place at the time, but speaking of it isn't safe.
yeah.
So you've got that, plus you've got the whole part of society that puts everybody that's a disabled person over in that corner and separates them from female and male and everything else, as if, you know, disability is some kind of genderless thing that goes off into a subsection.
Yeah.
So when you're dealing with that, why would you kind of come out and say I'm suicidal? So there's really no way to kind of view it until it kind of has somebody like us to kind of put it out there as a topic.
Yeah. Yeah. Okay. Well, thank you so much, Desi. I'm wondering if you, if there are people here who are watching this today and they want to connect with you, how can they reach you?
I have a website and I am on Facebook and Twitter. I'm in all places except for my website as the same as I am here. So it's just at this. You'll find me on either one. And my website is powerfullypowerless at wordpress.com or .wordpress.com.
Okay. Okay. I love that. I love that title. That's good. And so just a reminder to any of our listeners who are feeling suicidal or thinking about suicide to make sure to reach out to your coach or your therapist. If you don't have someone, to reach out to your community mental health resources, your doctor, and you know, the text and the phone crisis lines in a pinch to get some help.
Thank you, Bobby, and thank you, Desi. I just want to say thank you, Desi. This is such a tough subject to approach, and I know I applaud you for having the confidence, you know, to come out on here and share with us everything, you know. So I just want to say thank you to all our viewers today. We hope that you're still enjoying the summit. We've still got plenty of videos for you to come and watch, and we hope to see you all soon. But until then, take care, everybody.